All right, so any questions from the last section of slides we were talking about last week, prior to the storm? Anything at all? All right, so continuing on, we'll continue to talk about our asthma medications. So we already talked about our short-acting beta agonists, like our rescue medications. Next, we're going to talk about some of our controller medications. So one of the big groups here is going to be our inhaled corticosteroids. So what's the benefit of using an inhaled corticosteroid versus a systemic one?
Less side effects.
Not fast, right? Because steroids are always going to work slow for the most part. But yes, less side effects are the big thing because you're going to be working locally in the lungs, not necessarily out in the rest of the body. So a couple different varieties you can get here. You can see beclomethasone, flunicillide, fluticasone, all kinds of different ones. Notice here that a lot of them have their nasal preparations as well. So it's important not to get those mixed up. It's a common error to get things like, say, Flonase and Flovent mixed up. You get wrong dispensing from the pharmacy. So it's why a lot of cases they would recommend, say, if you're writing prescriptions, say, put fluticasone nasal spray, put Flonase, or put fluticasone inhaler, Flovent. That way, it's a little bit more conspicuous, and people are less likely to dispense the wrong product. So just be aware of that kind of look-alike, sound-alike products there. So we know they're going to be working by kind of inhibiting the inflammatory cascade from the top pathway, right? So they're working from the side of the nucleus. They're going to be inhibiting, transcription of those genes that are responsible for making inflammatory cytokines. We also know that it's going to take time for these guys to work. So if you were looking at the speed of onset, if you're comparing systemic corticosteroids versus these inhaled corticosteroids, these are going to take longer to work. So this is a very important counseling point for your patients to make sure that they're going to take the drug consistently and they're going to take it as prescribed every single day. Usually twice a day is how you'll see these prescribed. Because otherwise you may have a patient comes back and says, hey, I'm not getting any better, this is not really working, and they've only given it a couple days, right? So it's important to make sure that they're taking it for the appropriate amount of time and before you can make any decisions on how you change doses or change drugs or anything like that. As far as adverse effects go, they're going to be pretty well tolerated as compared to your systemic corticosteroids, but one of the big things, and another good counseling point, is that they are going to be at risk for developing oral candidiasis or thrush. Why do you think that is?
Because they don't breathe it.
Well, so if they're inhaling it, one of the first places any kind of inhaled drug is going to go is to the back of the throat, right? So because it's causing a local immunosuppression there, you're more likely to have that thrush infection develop. So we always recommend after using the drugs to make sure they swish their mouth out with water and spit. Okay, so it's a good counseling point for them as well. Other things you may see, which are pretty rare, there may be some risk for things like growth suppression in children, but this is exceeding the high doses. And again, you may see some inhibition of the immune system systemically, but it's very unlikely using normal doses of these inhaled corticosteroids. So really that oral thrush is the biggest thing to worry about. We do see combinations of some of these drugs, so frequently you'll see a long-acting beta agonist like formoterol and salmeterol in combination with an inhaled corticosteroid. So you see things like Symbicort, Advair, and again, you will see some immediate benefit from using these combination products because the long-acting beta agonists work pretty quickly, right? They're not going to work as quickly as a short-acting beta agonist like, it's a good example of one. Yeah, albuterol, it's kind of the example of one, right? So they will not work quite as fast as that, but once they're on board, they're going to help provide some control throughout the day while those inhaled corticosteroids take time to work, right? So why would you ever put someone on just a steroid by itself instead of putting them on a combination product?
That's not what they're made for. That's not what they're made for.
So if you're trying to control symptoms of asthma,
right,
why would you not put them on a combination product?
because you want immediate relief. Like, say you want albuterol.
Sure. So every asthmatic patient will have albuterol as kind of a rescue medication, right? So I guess the thing I'm trying to get at is that these medications are generally much more expensive than the inhaled corticosteroids by themselves. So in a lot of cases, if your patient can't, if they don't have good insurance, this stuff may be prohibitively expensive, right? So if they can't fill the prescription, they're definitely not going to get any better. So frequently, if your patients are having more mild symptoms, mild persistent symptoms, then you can get away with using, say, an inhaled corticosteroid by itself. If that's not really resolving it, then potentially you can add them on to one of these combination products, right? So usually you're going to see these stepwise approach to adding these medications on board. So it may be worthwhile for patients who have more mild symptoms to start with the steroid by itself and then go combination. If it's pretty severe, moderate to severe, persistent asthma, then you may consider doing combination right off the bat. Just depends on your patient. Some other controller medications we'll look at, including working on the leukotriene pathway. So we saw that when you have arachidonic acid being liberated from the membrane phospholipids, one pathway was for cyclooxygenase to start the production of things like prostaglandins. You're going to see that there's another pathway that forms leukotrienes. I'll show you a picture of that in just a minute. So when you have leukotrienes, they're really responsible for a lot of the bronchoconstriction and things like that happens in asthma. So if we can get something that blocks leukotriene at the receptor site, prevents them from working in the first place, and you can maybe help have some additional control of asthmatic symptoms. So two drugs here, zafirlukast and montelukast. Montelukast is going to be the one you're going to see primarily used clinically. Zafirlukast has some issues with it, including a lot of CYP inhibitions that make it really kind of difficult to use clinically without causing a lot of drug interactions. So Singulair is definitely the one to go with. Actually, it should be Singulair like AIR at the end of that, so that's a little misspelled. So anyway, they're blocking these LTD4 receptors, preventing bronchial constriction, preventing inflammation and mucus secretion. And these are going to be more for controller type medications, right? So you're not going to take these for an acute asthma exacerbation. These are going to be more like daily chronic therapy. And then also these can be utilized potentially in patients who have aspirin-induced asthma. So I'll show you what that pathway is in just a second and why that could potentially work. Another drug that works on the leukotriene pathway is going to be Xyluten or Zyflo. This one's pretty rarely used. It additionally has some CYP interactions which make it problematic. But this one directly inhibits the enzyme 5-lipoxygenase, so you can prevent the leukotrienes from actually being formed in the first place. So if you look here, you see arachidonic acid, you have cyclooxygenase that is inhibited by what type of drugs? A cyclooxygenase is inhibited by what type of drugs? Yeah, NSAIDs, right? So that's responsible for producing things like thromboxane and prostaglandins. This other side of the pathway is this 5-lipoxygenase, and so you see the leukotrienes being formed from that enzyme. So once the leukotrienes are formed, then that's where things like montelukast can block the receptors, and you see some benefit there, whereas that Xyluten is going to work directly on the 5-lipoxygenase. So when I mention aspirin-induced asthma, there are a subset of patients who will actually have asthma attacks induced by NSAIDs or induced by things like aspirin. The reason for that is when you block cyclooxygenase from preventing production of things like prostaglandins, you end up shunting a lot of that over to the other side. So you end up having a lot of extra leukotrienes being made because that 5-lipoxygenase pathway is kind of being ramped up. So because of that, that can help to induce an asthma attack. So if you have a patient who had aspirin-induced asthma, you could potentially put them on one of these leukotriene receptor antagonists and actually prevent those symptoms from occurring in the first place, right? So maybe if you had a patient who you wanted to be on aspirin for cardiovascular protection, you could put them on montelukast as well to help prevent that from occurring. Does that make sense? Or that pathway, how that gets shunted over? Okay. So other issues, certainly with Xyluten, especially you can see some issues with liver damage. You see this a little bit with zafirlukast as well. Just some signs of liver dysfunction, including anorexia, abdominal pain. Jaundice is obviously a pretty worrying sign. If they start, if they come into your clinic looking yellow, something's up, right? And then for the most part, the leukotriene receptor antagonists are pretty well tolerated. You may see some, kind of non-specific, headache, heartburn, things like that. But they're very well tolerated. Pretty benign for the most part. So many patients who will take it and not really have any side effects associated with it. And typically you'll see montelukast being used as adjuvant therapy. So it's being kind of added on if their symptoms aren't being completely controlled with the use of inhaled corticosteroids. So some things we can do to potentially prevent the asthma exacerbation from occurring in the first place is if we remove the trigger of the antigen. One of the ways we can do that is to work by stabilizing mast cells. So we talked about some mast cell stabilizers already. These are of pretty limited use. And why do you think these mast cell stabilizers are of limited use? Yeah, it's only going to be for prevention. And even then, you're only kind of blocking really one kind of step of the pathway. So these are pretty... not all that effective for the most part, and they really don't get a ton of use because of that. So we'll just mention these for kind of completeness sake. You may see them used every once in a while, but usually not very commonly. But you have cromolyn, netocromel, both have inhalation products that are available. Again, they need to be taken before the actual insult occurs to be effective. Again, the mechanism is not completely known, probably something to do with calcium and preventing that from activating the mast cells when then the antigen is working in tandem with those. So again, these also need to be taken for a period of time before you can really assess effectiveness, so say up to 4 weeks before you'll see total efficacy. And again, it's one of those things where let the patients know that it's going to take time and not to just say this drug's not working and discontinues too early. Again, side effects pretty non-specific, may leave some bad taste in the mouth, but other than that, it's pretty well tolerated as well. So this drug does get used with a little bit more regularity. So I see this being used in patients who have very significant allergies and are very difficult to control on other asthma medications. And so this one's called omalizumab, otherwise known as Xolair, so it's a little easier to say. So I see this very frequently over at Nemours dealing with in the pulmonology clinic. So kids that are very difficult to control asthma, they'll end up getting put on this drug. And so have we talked about any monoclonal antibodies previously? Okay, so anytime you see a drug that ends in the letters MAB, that stands for monoclonal antibody. You see a lot of these being used for things like autoimmune conditions, so rheumatologic conditions, ulcerative colitis, Crohn's, RA. You'll see a lot of MABs being used in those situations. This one is used primarily for asthma. And so basically what a monoclonal antibody is an antibody that's being targeted towards a specific molecule or receptor or whatever it happens to be that is targeted specific against. So the nice benefit is it's very specific. It's not likely to cause a lot of systemic side effects because it's really only affecting one particular target as opposed to some other systemic drugs which can affect tissues throughout the body. The other problem with this though is that it's a protein. And so anytime you inject a protein in the bloodstream, what's a potential risk? Not embolus. You have foreign protein in the bloodstream. Yeah, immune reaction. So anytime you inject a foreign protein into a person, immune reactions are possible, including anaphylaxis. So also they're very expensive to produce. So these are typically therapies they're going to go on when they failed kind of a lot of other things first. So you'll see it's given subcutaneously. You give it every 2 to 4 weeks or so. So they're having to come back into the clinic pretty frequently in order to get checkups and get administered the drug. So good, and this one is specifically targeted against IgE. Yes?
So the provider gives them this. They don't get a prescription for this.
So they could get a prescription for it, and so say for instance, and I guess everywhere might do it a little bit differently, but what we would do at Nemours, because we have the pulmonology clinics in the hospital, what they'll actually do is we have the and this is one of those things where insurance companies are not going to cover it unless you have documented evidence of failing other therapies. So this is one of those things where you require a prior authorization. Have you guys heard of that before? So essentially, it's a non-preferred drug. It's very expensive, and so the insurance companies want to make sure that if you get prescribed it, it's for a good reason, right? So this requires to come back to the provider to get the prior authorization signed off on, and then you send it to the insurance company and say, okay, we'll cover it. So what we would frequently do is, because we had the hospital pharmacy there on site with the clinics, is that we would actually have the drug company ship the drug to us after they got the prescription, and then it would get billed through all the insurance and stuff. And then we would actually prepare it in the IV room. And then we'd send it over to the clinic where it could be administered, and the nurses would administer it there. So that's kind of our process. Potentially they could be writing, you could be writing a prescription for it, they would fill it and then bring it into the clinic to get administered. So the issue is, because there's some drugs that patients can administer subcutaneously at home, so if they're on insulin or something, they can administer their own insulin. With this drug, because it's being fairly infrequent, and then also some of the side effects associated with it, you don't want them to necessarily be getting it at home, so this is why we do it in the clinics. Mainly the anaphylaxis risk is the big thing, right? So usually we're going to end up watching them for some period of time after they receive the drug to make sure they don't have any specific reactions. And then once you've given it a few times, you kind of get an idea of how the patient's going to tolerate it, and then you may not have to watch them for as long. It's maybe 30 minutes or so, and then send them on home, right? So again, there's also risk for secondary malignancies. It's not necessarily a hard and fast rule, but there is some concerns that by giving this, you may see some secondary things like leukemia or something pop up, but it'd be pretty exceedingly rare. Again, so just urticaria, anaphylaxis. Certainly, you can see some bruising, injection site pain. Those are probably the most common adverse reactions, with the anaphylaxis being pretty rare for the most part. But again, it's definitely something of concern, because if they're having anaphylaxis, then you want to be able to make sure they're in a place where that can be treated pretty promptly. All right, then moving on from there, another group of drugs you're not going to see used very frequently. We have the Methylxanthines. The main drug we're going to talk about here that falls in this category is going to be called theophylline. And the IV form of this is actually called aminophylline, so A-M-I-N-O-phylline. Does anyone know another very common methylxanthine that is probably frequently abused by PA students? Not Adderall, but another type of stimulant. Caffeine. Yeah, caffeine is actually methylxanthine. So, sometimes you actually give neonates caffeine because it actually can stimulate their respiratory drive and stimulates your guys' studying drive as well, obviously. But in the same chemical class as theophylline. So this drug works as a non-specific phosphodiesterase inhibitor. And so phosphodiesterase, we probably haven't really covered this because we haven't looked at calcium channel blockers yet. But phosphodiesterase is an enzyme that's responsible for metabolizing a second messenger called cyclic GMP, or cGMP if you see it there. cGMP is responsible in a lot of smooth muscle for causing relaxation. So here, this makes sense because if you have an asthma attack, you're having bronchial smooth muscle constriction. So by giving a phosphodiesterase inhibitor, this can help to induce relaxation of that bronchial muscle. And that's how we think it's going to help with some of the asthmatic issues we're seeing, right?
That metabolizes what?
Cyclic GMP. And so by inhibiting that phosphodiesterase, you see higher levels of cGMP, and thus you're going to have more smooth muscle relaxation. Does anyone know of any other phosphodiesterase inhibitors that are pretty popular amongst, Yeah, Viagra. So like your erectile dysfunction medications work specifically on this enzyme as well. You have different isoenzymes of this, so there's different varieties of the phosphodiesterase in the body. So some are going to work for erectile dysfunction. We actually give small children Viagra every once in a while because they have pulmonary hypertension, because that same enzyme is also seen in the lungs as well. So you can see that being given there. So if you ever see like a little girl who's on sildenafil or Viagra, it may seem a little odd at first, but then you realize, oh, she probably has some kind of cardiac condition or pulmonary condition that really necessitates that. So, anywho, so it has that kind of activity. We don't use it very frequently because it's less effective than a lot of our other controller medications like your long-acting beta agonists, your inhaled corticosteroids, and is much less well tolerated. So this is a drug we term to have a narrow therapeutic index, which means that the area or the blood levels where it's therapeutic and where it's toxic are very close to one another. So very similar to how we saw therapeutic drug monitoring being done with like our aminoglycosides and vancomycin, the same thing is going to be done with theophylline as well. So, and some of those issues we see when it gets up to those toxic levels include arrhythmias, convulsions, all kinds of issues, lots of GI issues are seen with this as well. So again, it's an old school drug. The most frequent people you'll probably see on it are going to be kind of little old ladies who've been on it for probably 40 years and their docs have never changed them off of it. That's probably the most frequent ones you'll see. Rarely, if we have like a kid who comes in to say the PICU and they're having really severe status asthmaticus, right? So that's an asthma attack that really is not really responding to anything. Rarely will we actually put them on the IV formulation to help get some extra bronchodilation occurring in there. So you'll see it used pretty rarely, but when it is being used, at least identify and be aware of it. So sometimes you might see a little bit more frequently using COPD just because those patients may be a little bit more refractory to other medications. So again, it's working by inhibiting that phosphodiesterase. We see increased levels of cyclic GMP and also cyclic AMP, which are both going to help with the bronchodilation. It also works as an adenosine receptor antagonist. Adenosine is a molecule that your body naturally produces that really works as kind of an inhibitory kind of molecule. So if you put it on the heart, it actually can stop the heart, right? So that's actually a drug we'll see used as an antiarrhythmic. If you put it in the brain, actually will stop seizures. If you antagonize it, though, you can actually see increased excitation. You can see seizures. You can see arrhythmias if you block it. So that's why we see some of the issues with this drug when the levels get too high, is by blocking that adenosine effect. Do you have a question? See your wheels turning. Okay. Yeah. And then it's also thought that theophylline has some anti-inflammatory actions as well that can help with some of the late phase reactions we see with asthma. Yes?
That adenosine thing has nothing to do with ATP, right?
Not that I'm aware of. Yeah, there might be a second messenger somewhere down the line that uses it, but typically adenosine is just blocking adenosine, or adenosine works on adenosine receptors. It makes pretty easy sense. Yes?
So what you said, it stops seizures in the brain and also can stop the heart as well?
So if you were to, so say for instance, because it's an inhibitory molecule, so like for instance, if you have something like a supraventricular tachycardia, heart rate's going 180, ventricles trying to keep up, right? So you can actually give adenosine and actually stop the heart for a second and actually reset the rhythm of the heart, right? And so because if you antagonize that, if you block the effects of adenosine, that's why you can see tachyarrhythmias, right? Because you're removing that inhibitory effect. So that's why theophylline can cause those arrhythmias. Same thing can happen up in the brain. If you block the effects of adenosine up in the CNS, you can actually cause seizures to occur because you're removing that inhibitory effect, right? So that's why we see a lot of the side effects associated with this. So again, adverse effects, you see a lot of GI issues with this. You could see a lot of smooth muscle relaxation. So not only is that going to be seen in the bronchial smooth muscle, but you can also see that on the vascular smooth muscle. So you can see hypotension develop from this as well. And if you're looking at other side effects, so again, we're looking at blood levels of the drug, and keep in mind this one is renally eliminated, so you really need to check renal function for these patients, because again, if that changes on you and you haven't changed your dose of the drug, you can accumulate drug very quickly, and then once this drug gets into the CNS, it's very difficult to get out. So convulsions and seizures are going to be very, very frequent, especially at levels greater than 20 micrograms per ml, and arrhythmias can happen here in addition. So just looking at a therapeutic level of theophylline could be anywhere between 5 and 20 micrograms per ml. Notice that the toxic effects already start at 15, and really significant effects can be seen at 30. So really there's not a whole lot of play in regards to where you see efficacy versus toxicity. So 40 years ago, this was the only drug you had available to treat, but nowadays you have much better agents with less toxics. We don't have to use this very frequently. Probably one of the worst theophylline toxicity that I saw was actually a little old lady who came in. She's probably 84 or something. She was in a nursing home and been on theophylline for several decades. She had a hit to her renal function. She was dehydrated. No one actually caught it, and so she ended up accumulating very significant amounts of theophylline. Came in seizing, and again, like you said, once it gets into the CNS, it's very difficult to get out. So we were actually able to dialyze the drug off, where you do hemodialysis to pull the drug off. But unfortunately, her CNS levels are so high that she was just in non-convulsive status epilepticus, and she unfortunately ended up dying from that. So very scary drug to mess with. That's why we use it very infrequently. Okay, some other drugs we can use. So one of these will be a shorter acting medication that will be considered kind of one of your rescue medications. So these would be your anticholinergics. So they're going to be blocking the effects of acetylcholine on the muscarinic receptors, right? And that's going to help to cause bronchodilation. So we mentioned previously on the last set of lectures that drug methylcholine, which we actually use as a provocative test. We actually give it because it works on those muscarinic receptors to induce an asthma attack. So here you can see we use anticholinergics to reverse that effect. So the short-acting agent is called ipratropium or Atrovent. And then the long-acting agent, where we only see used for COPD, is going to be tiotropium or Spiriva. Okay. Usually when you're prescribing rescue medications for your patients, you're only really going to send them off on an albuterol inhaler. You typically don't give them an Atrovent inhaler as well. But if someone were to come into like the emergency department, very frequently you see them getting administered albuterol and ipratropium just to kind of get a little extra oomph to that to try to help cause that bronchodilation. Okay, so typically you see like albuterol and Atrovent for 3 doses, every 15 minutes, for 3 doses, and then it's usually kind of you have an idea whether or not how reversible they're going to be, and if you have to initiate kind of other therapy. So that's something you definitely might see. Spiriva is kind of interesting. You'll notice that there's lots of different varieties of inhalers see being used. Give me a pause real quick. So anywho, so there's lots of different types of inhalers that are out there. So when I say an MDI, that's typically going to be one of the normal, what you imagine, kind of a squirt inhaler. That stands for a metered dose inhaler, right? So every time you hit the canister, you get 1 dose out of that. It's a metered dose. Usually, like for albuterol, you get 90 micrograms, whatever it happens to be. There are also DPIs, or dry powder inhalers. Typically, if you see one that comes like in a discus, where you actually have to you kind of roll it open, or turn it open, and then you would actually hit a little trigger to puncture. There's actually capsules in there that have the powder. You hit that trigger to puncture the little packet, and then the patient is going to be inhaling the drug itself. So the big difference there is that one with the meter dose inhalers, like the propellant in there is what's putting the drug into the system, versus the dry powder inhalers, you're relying on the patient to inhale that, right? So if they're a particularly old patient or young patient and they can't really cooperate very well, they may not have really the faculty to actually inhale that, right? So that can be an issue and why you might decide to use a meter dose inhaler versus a dry powder inhaler. Spiriva is kind of interesting because this is a drug that actually comes as a capsule form, and so it has a special device where you'll actually put the capsule into the inhaler. You'll again have a puncturing device. You'll hit the button, and the patient can breathe it in from there. But I'll tell you, working at the poison center, you get a ton of calls from elderly patients who are like, "Oh, I just put all my meds together and accidentally swallowed my Spiriva. What do I do?" So that was a pretty frequent one. Unfortunately, it doesn't really get absorbed systemically, so really nothing. But again, it's a good idea to make sure you let your patients know, hey, don't store this with all of your other medications, your tablets and capsules, because it'll get mixed in and you'll accidentally take it. If you ever hear HFA That basically just stands for the type of propellant they're using. I don't remember the old, I think it was a CFC-based propellant. They were worried about it damaging the ozone. I'm sure all the albuterols and inhalers in the world probably wasn't doing that much damage to the ozone layer compared to some other things, but they ended up switching it over to HFAs. So that's the new propellant they use. So if you hear that, that's what that's referring to. Okay, so as far as adverse effects that you can see from anticholinergics, again, by giving these drugs just in the lungs, you're less likely to see systemic effects, but just to kind of put it out here in case we haven't talked about it previously, here's the mnemonic to help you remember antimuscarinic side effects. So again, they're blind as a bat, so you can see mydriasis, blurry vision due to muscarinic effects on the eyes, mad as a hatter, so you can see some altered mental status, you can see hallucinations, delirium, red as a beet, so you'll get, probably should be BEET, so you see flushing due to some cutaneous vasodilation. They'll be hot as Hades, so they're going to have hyperthermia, dry as a bone, so they'll have dry mouth, dry eyes, urinary retention, and then they can also have tachycardia associated with that as well. Yes?
Is muscarinic and cholinergic the same thing?
So cholinergic just refers to acetylcholine, right? And then so there's two different varieties of that. You have your nicotinic and your muscarinic, right? So nicotinic receptors are going to be on more like on skeletal muscle, and they're also responsible for like kind of nerve conduction through the central nervous system. The muscarinic are going to be more on the tissue, working to control a lot of these effects. So these anticholinergic effects are specifically antimuscarinic effects. Okay.
And you said the other one was called what?
The nicotinic receptors.
Nicotinic.
Yeah.
That's on skeletal muscle.
Primarily on skeletal muscle, but also like if you have like a synapse happening, so you say you have an initial nerve impulse going down and it's connecting to a synapse, that's usually going to be nicotinic as well. Or that's again where you can see some nicotinic receptors being found. Does that make sense? Okay. So then if you need additional control, so say you are, you have your patient who's on their controller medications and they continue to have asthma exacerbations, they're using their short-acting beta agonist and it's not really working, potentially you can use short doses or short courses of systemic corticosteroids in order to help decrease that inflammation occurring. So this helps to suppress, control, and reverse that airway inflammation that's happening there. Again, it's going to work similarly to the inhaled corticosteroids, but this just works systemically. These are typically going to have, while they still take time to work, you're going to see these working much more quickly than you would see with your inhaled corticosteroids, much more potent. So that's why we really save them for exacerbations and only use them for short courses of time. So frequent ones, we've seen these before. We talked about anaphylaxis. We have things like prednisolone, which is just a liquid form, methylprednisolone, which may be given parenterally or IV, IM. That would be more for more severe exacerbations. And then you have dexamethasone, which could also be used parenterally as well as orally. So we talked about the side effects. Now, when I say adrenal suppression, what does that really mean?
You're inhibiting the excretion of adrenal glands.
Yeah, so by giving those exogenous corticosteroids, your adrenal glands eventually are going to say, hey, I don't need to secrete anything, so they start to shut down. Typically, you're going to be giving these doses for less than a week or so. So typically like 5 days, you'll see a lot of these short doses of steroids being done for. And if it's less than a week, you really don't need to worry about tapering the dose. If it's more than that, then you should consider starting to taper down the dose over the course of several days. So say, for instance, if you have a patient who comes into the emergency department for an asthma exacerbation, you send them home on a course of 5 days worth of steroids, you can do the same dose every day, and just once they're done, right? As opposed to, say, they were to come inpatient and say they had a really bad exacerbation, they were on steroids for 3 or 4 days, and then you send them home on 5 days worth, then you might be able to taper into it over the course of a few days in order to help prevent that adrenal suppression or prevent that withdrawal that can occur to lead to adrenal insufficiency, right? So again, a lot of these effects are going to be more seen with chronic dosing. You usually don't see a ton of it with just kind of short course therapy, but potentially you run the risk of having things like immunosuppression that could lead to secondary infections. Especially if it was a viral illness that put them into the exacerbation in the first place, and now they have this additional immunosuppression. Now they get a bacterial infection, right? So that could be a potential. So how do we go about treating a patient with asthma? Essentially, it's a stepwise approach where you kind of add on medications based on their severity and based on response to whatever you put them on previously. So step one, just about everyone's going to be on a short-acting beta agonist for as-needed therapy, right? So especially if you have a patient who's only having like exercise-induced bronchospasm, they just need a short-acting beta agonist. They don't really need any additional therapy because they have a known trigger. They know when they're going to be exposed to it. They can use it beforehand and prevent it from occurring, right? Once they're having more kind of persistent, intermittent asthmatic episodes, then you want to start to add on a controller therapy. So initially, especially for more minor symptoms, you can consider just using a low-dose inhaled corticosteroid. So that's the ICS there, right? If that's not particularly working, you can consider, especially once you give it a long enough course to work, then you can consider using either a higher dose steroid, so you can increase the dose of what they're on, or potentially adding on a long-acting beta agonist. So that's where you can use that combination therapy there. And then if that's still not working, then again, kind of optimize your doses of everything. And that's when you need to start considering adding on other agents, like adding on, say, montelukast, leukotriene receptor antagonists. Or then if that's still not working, then you want to consider adding on something like omalizumab or Xolair, right? So basically, you kind of start a new therapy, see how they do, come back, look at their symptoms, look at, have them keep a diary, see how often they're waking up at night or how often they're using their albuterol inhaler. And then based on that, you can kind of make decisions on how you either scale up or down therapy. Right? That makes sense? Okay. All right, so I'll just go over this part real quick and then we'll give you guys a break. So a couple of different devices you can use to administer asthmatic medications. We already talked about the different types of inhalers. What's another way that we can administer some of these drugs? Let's talk about like specific inhalers. Yeah, so nebulizers. So what does a nebulizer do?
Uses oxygen to
Makes into a mist.
Yeah, essentially, so you can see, yeah, basically just aerosolizing the drug. So typically you'll have a compressor with some tubing hooked up to it, and you'll have a cup that you'll basically put the drug into, and then you'll turn on the compressor, and that compressed air will end up causing an aerosolization to occur as we get the nice big smoke clouds and everything of albuterol and things. So what's kind of some of the downsides of using a nebulizer?
not really portable.
Not super portable.
Yeah, not portable. What else?
They're difficult.
So you're more likely to do it right with the nebulizer, especially if you think about compliance with especially patients of either extremes of age. So if you had a patient who can't really use an inhaler correctly, and we'll talk about technique in a second, that might actually be better. So if you're trying to do it for, say, like a 6-month-old child, putting a mask on them with the nebulizer hooked up to it is very easy because they're just passively breathing it in. So that's actually a good thing. Yeah.
Don't you get like more medicine in, so you're more jittery?
Exactly. So you get a lot more medicine in the system. So you see a lot more systemic side effects. So say, for instance, like when I was a kid growing up, I would use my short-acting beta-2 agonists, pretty frequently because I didn't have any controller medication on board, so it definitely wasn't being managed appropriately. But neither here nor there. So whenever I would get sick, I had a virus or something like that, I would get my short-acting beta agonist really wasn't cutting it anymore. So I would get some nebulizer treatments, and so you just inhale the stuff, and it's over like 15 minutes or so that you can inhale the dose. And if you think about it, if I do 2 puffs of albuterol, it's basically 180 micrograms. When you're doing a nebulizer's worth of albuterol, that's anywhere between 2.5 to 5 milligrams. So much, much bigger dose. Not that you're inhaling all of that, but you definitely inhale a lot more. So you're more likely to see systemic effects. So you get really jittery, your heart rate goes up, you can see potassium shift inwards. So you're more likely to see systemic effects from that. But you also have the ability to have non-compliant patients actually get the dose in, right? So that's kind of one of the benefits of it. So some other things that you can do to help patients get the dose in, because one of the things that you see with inhalers is that the particle size is really important. Because if a particle is too big when you try to inhale it, where's it going to go? You just swallow it, right? So they actually were doing studies and I wish I had some pictures of it, but they'd had a radio-labeled product, and they were actually looking at particle size, and they would actually do scans on the patient after they did a dose to see where the drug ended up. In a lot of cases, the particles are too big. You saw it just going down the esophagus, right? Particles need to be they can't be too small, because as soon as you inhale them, you can exhale them right back out. So they need to be right, kind of the Goldilocks size to be able to get right into the lungs to really where they need to work, right? So just right. So some of the things we can do, because if a patient is inhaling inappropriate, so say they're going too fast or they're going too slow, they can also have issues getting the dose in. We can use things like spacers and valve holding chambers. So if you ever see an inhaler with a big, cylindrical plastic tube attached to it, that's typically a valve holding chamber. And so essentially what that does is it removes the need for patients to have a really coordinated activity to pressing the canister and inhaling appropriately to get the dose in. What you can do with those is you press the canister, the drug goes into the chamber where it's being held, and then the patient can kind of breathe it in as they will, right? So, and then it's also nice because if you go too fast, it'll kind of start whistling at you, so you know you're going too quickly. So you can breathe in, nice controlled inhale to get the drug where it's supposed to go. So that's one of the benefits. And actually, when they looked at studies comparing patients getting doses via multi-dose inhaler or meter dose inhaler via valve holding chamber versus the nebulizer, it's equal efficacy, but no additional toxicity with using the meter dose inhaler. So there's some benefits to that, but again, a lot of times if they go into the emergency department or urgent care clinic, you'll typically get a nebulizer just to really get as big a dose as you can. So does that make sense for everyone? All right. So technique is super important for inhaler use. If they have bad technique, they're probably not going to get enough drug, and then you may think they're failing therapy when really that's just a technique issue. So really, first thing when you're using a meter dose inhaler, you take off the cap and you shake up the inhaler. Why do you shake it? Make sure if it's a suspension, make sure it gets mixed all the way throughout. And then one thing that a lot of thrifty patients don't like to do is you have to prime the inhaler the first time you use it, because otherwise you may squirt it and you not actually have any dose in the chamber, so to speak. So you need to do say like 3 to 4 puffs in order to actually get the drug, make sure they're getting a consistent dose. So have the patient exhale, and then I have them start to inhale, and as they're inhaling, actuate the inhaler, right? So it needs to be kind of, you start to breathe, and then what that does is that starts to have, you kind of get a good airflow going down into the lungs where the drug can just travel along with it. Versus if I squeeze and then breathe in, it's all going to hit the back of the throat, and then I get some of it down in the lungs, right? So it needs to be kind of start to breathe in, hit the actuation, and have them breathe in, hold it in for about 10 seconds or so, or however long they can hold it, and then they can breathe out as normal, okay? Yes?
Why don't patients like to prime it?
Because again, they think they're wasting doses. Yeah, especially if they see a little counter on the back of it and they're like, oh, I don't want to waste money on this stuff. This is an expensive inhaler. You'll find a lot of patients will do weird things to try to be thrifty. Yeah. So again, make sure that if they're using multiple puffs, not to use them in succession. You want them to give it a little bit of time to work. So at least 30 seconds, maybe even a minute, because that first dose of albuterol is going to help to start to open up that bronchial smooth muscle, and then that allows the second dose to get even deeper, right? So it's important to make sure you give some time for that stuff to work. So any questions on that? Again, if they're using inhaled corticosteroid, what do you tell them to do afterwards? Rinse their mouth out and spit, right? Because you don't want to worry about the thrush risk. Okay, so again, this is a chronic disease. It's important to make sure we're having the right rescue medication on board, plus appropriate long-term controller medications to help prevent these exacerbations, prevent mortality, hopefully. And just make sure, trigger avoidance is really important as well. So especially if they know they're going to be exposed to something, maybe doing a dose beforehand to help prevent the actual exacerbation from occurring. So next, we'll talk about COPD, or chronic obstructive pulmonary disease. So big difference here with our changes between asthma versus COPD is that with COPD, you're having more chronic inflammation, you're having chronic damage being done to the lungs over time. So in general, you're going to see that these effects are not completely reversible. Whereas with an asthmatic patient, I can give them a dose of albuterol and I can completely reverse their bronchospasm. Here, they're always going to have some underlying degree of lung impairment, so you can never really get full reversal of all their effects. And here you're going to see this accelerated decline of FEV1 over time. Notice that these patients can be pretty asymptomatic for a long period of time as they're still doing damage. Lung function is going down, but then once they get to a certain point, and that's where we're going to start to see their symptoms start to creep up. So that's that blue line there. You can see as the lung function continues to go down, symptoms are just going to get more and more severe to the point where they're really not aerating hardly at all. So transplant is going to be potentially needed. We talk about hospice care and things like that. It can get very, very severe for these guys. So obviously, big cause is going to be smoking. So we'll talk a little bit about smoking cessation towards the end of the class here. Also other causes, so you could see things like alpha-1 antitrypsin deficiencies. Even some degree of indoor air pollution could potentially lead to development of COPD. But smoking is going to be the big one that we'll focus on for preventable causes. Yes?
This is totally off topic. Do you know how to explain restrictive versus obstructive disease?
Oh gosh, it's been a while since I've talked about that. I can't say that I can speak intelligently enough to it right off the cuff to not get you guys confused, so I will refrain from that for now.
Okay, that's cool.
Yeah, I would. Whether they're a pink puffer or blue bloater and all that good stuff, yes. That's the extent of it. One's basically an issue if they just can't expel the air versus one where they just really can't get it in, So, but again, I haven't looked at it close enough recently to give you guys a clear, concise review. So talk to your patho teacher. Okay, so going in here, you won't see any new drugs being utilized for COPD than we've talked about for asthma, but the way that you're going to initiate these drugs will be a little bit different. So again, for short-acting, for rescue inhaler, they'll start off with an inhaled beta-2 agonist, short-acting one for relief of symptoms that are acute. When you start looking at more chronic therapy for control of symptoms, that's where you're going to see either a long-acting anticholinergic or beta agonist being used. We said previously you don't want to use a long-acting beta agonist on an asthmatic patient by itself because they actually saw increased mortality with that, right? So you really would want to start off with an inhaled corticosteroid for an asthmatic, then add on a beta agonist, long-acting. Here, you could potentially either use long-acting anticholinergic or long-acting beta-2 agonist, right? Either one are going to help to prevent that bronchoconstriction that we're worried about there. So then once you add on, say their symptoms are not still controlled with one of those, then you can consider using combination therapy. Then at this point, it gets a little bit more murky. Some people may consider adding on theophylline to get some additional benefit there, but probably more frequently just due to side effects and due to not needing really any kind of therapeutic drug monitoring, you'll see an inhaled corticosteroid probably being added on at that point, right? So just the difference here is that asthma inhaled corticosteroids are typically going to be more initiated much more early on than you would see with a COPD patient. Then from there on, you're just kind of optimizing your doses. You need to consider looking at things like more invasive therapy. You need to look at adding on supplemental oxygen, surgery, transplant, as we have to consider all of that. But that's mainly how you're going to be adding on these drugs. Other things we'll talk about include the drugs for smoking cessation, and then also important vaccines that they're going to require being a COPD patient, because we know that they are really impairing a lot of that their own protective mechanisms, right? We talk about those nice ciliated epithelia that like to bring up all the gunk in the lungs out. They lose a lot of that, so they're going to be much more at risk for having pulmonary infections. So as far as smoking cessation, how good do you think, what do you think of the success rates of quitting smoking? Pretty abysmal, right? What do you think the actual compliance is with therapies that you recommend? Probably pretty bad, right? So, we know nicotine's super addictive. We know it's very difficult to kick that habit. So a lot of the drugs that we're going to be seeing being used are going to try to replicate some component of the nicotine, whether it be its effects on kind of the reward pathway, dealing with dopamine, or whether it has to do with actually working on those nicotinic receptors itself. But we know it's a complex component. We know we have to go attack it from multiple pathways. So both, physiologic, social. We're really going to focus more on kind of the physical manifestations of that, because if someone quits using nicotine cold turkey, what happens? You go into withdrawal, just like you do from a lot of other medications, just like you do from pain medications or anxiety medications and things like that. Your body gets used and gets equilibrated to having all that nicotine around. You cut that off cold turkey, all of a sudden they're going to have withdrawal effects because their receptors have downregulated. They're just not really getting the same homeostasis that they were used to when they had the nicotine on board. So the group of drugs we'll talk about here. Has anyone heard of the drug bupropion before? Mm-hmm. Where do you use it at, or what do you use it for? Anyone know? Yeah, it's actually an antidepressant. We'll talk about the specific brand name that we will use for smoking cessation. And then we also have a lot of nicotine replacement therapies. And then we have this newest drug called Chantix or varenicline, which is going to work through a little bit different mechanism than the other ones. First one's going to be bupropion. That SR stands for sustained release. So this is a longer acting drug. And so we know that when you use nicotine and addictive substances like it, it's kind of stimulating that reward pathway in the brain, which mainly means dopamine. So dopamine is our major reward pathway neurotransmitter. So if we can give a drug that can kind of help stimulate dopamine levels, the idea is thought that you may be able to help lessen that withdrawal phenomenon, or try to help trigger that a little bit, so that way the patient isn't really having that big of a withdrawal effect from that. So here, what we do with bupropion is it works as a selective reuptake inhibitor for both epinephrine or norepinephrine and dopamine, right? So by doing that, it can help with depression, but here it can also help with the dopamine levels to actually help prevent some of those withdrawal effects and kind of help, hopefully, increase your chances for quitting smoking. So potentially, could you have a patient still smoking and be on this drug? Would you expect to see any kind of big major interaction just off the mechanism alone? You may have excess dopamine, but clinically you don't really see issues with that. So we'll see in a second where that can become an issue. But here, if you had someone who relapsed and continued smoking while on this drug, you don't really see a big issue with that. Okay, so that's kind of one of the big things to know. We'll talk about some drugs where that will not be such the case. These drugs take time to work. Oh, yes, go ahead.
So this drug just basically helps to prevent withdrawal as the patient themselves stops smoking?
So it doesn't help prevent the physical manifestations of withdrawal, but the idea is by trying to increase dopamine levels within the CNS, you help relieve a little bit, because as soon as they stop taking the nicotine, that reward pathway is going to be basically just not functioning, right? Because it's not being triggered by the nicotine anymore. So by increasing the dopamine levels, you can maybe provide a little bit of relief there by at least tickling the receptors a little bit instead of taking all the effect away.
But it's completely dependent on the patient stopping the smoke?
Well, yeah, so the patient, will start to taper down their dose, whatever it happens to be. But yeah, the idea is they would stop smoking, and this helps to increase their success chance, right? Just like we actually can see bupropion sometimes being used to help with weight loss, right? Because again, when you eat a nice, if I go to a Chinese buffet and get like 3 plates of sushi, I'm definitely tickling that dopamine pathway. But if I have bupropion on board, maybe if I'm cutting back, I don't want to see that being activated quite so much, right? So sometimes you'll see bupropion being used with a combination of another drug for weight loss. Yes.
Oh, I was just wondering because I know that people that stop smoking and don't do anything about it, they like eat a lot more and then they get huge. Like I won't
Potentially.
who in the family, but he just got like massive after not smoking because all he did was eat after, and then the moment he stops smoking, he stops eating. Or starts smoking again, he stops eating.
Yeah, exactly. That's why you see like a lot of like supermodels smoking a lot, because it helps to suppress appetite and things like that. Keeps you skinny. So one of the side effects. Yeah. Anywho, so big thing here is that patients with seizure disorder, you can certainly run the risk of having your seizure threshold decrease while on bupropion. So that's one thing to worry about, because you're increasing levels of norepinephrine and you're being more kind of stimulatory, so you want to worry about that. And then also you don't want patients to be on other drugs that are going to increase levels of norepinephrine in the CNS. So if they're taking a monoamine oxidase inhibitor, they're on another thing like a tricyclic antidepressant. We'll talk more about these in the psych lectures, I think probably in Pharm 2 if I had to guess. So don't worry too much about those interactions now. Just realize that they're there. That this is also an antidepressant itself, so you can have interactions with other antidepressants. But again, these are going to take time to work. So notice here, for 7 to 12 weeks, it's going to take a few weeks before the drug really starts to kick in fully. Okay. Yes.
Does this have anything to do with serotonin?
So normally a lot of antidepressants work by increasing levels of serotonin. They block the reuptake of serotonin. This one's a little bit different in that it works more on norepinephrine and dopamine. So while it's an antidepressant, it's a little bit more of an atypical one than you would see with something like a Prozac or something. Yep. Okay. Other things we can do would be nicotine replacement. So obviously this is similar to how you would see like a taper with a steroid. The idea here is you taper your nicotine dose, and also this is going to be much healthier for your patient because they're not inhaling a lot of that hot tar and all that kind of other carcinogens and things. So nicotine replacement has definitely been able to help with smoking cessation. The idea here is with these guys, because nicotine's already activating the nicotine receptors, you don't want to have smoking on top of this. So this would be the interaction where if they're using nicotine patch or using a nicotine gum, they don't want to be smoking at the same time, because then you increase your risk for toxicity from the nicotine itself, right? So don't use smoking in addition to this. Some varieties are going to be available over the counter. This can be good for them. So patches, gum are available. Make sure that they're taking patches off, they're disposing of them, and not just adding on a new patch, right? So some patients may be forgetful and have multiple on at the same time, which can also lead to toxicity. Again, if they have cardiovascular problems, nicotine is a stimulant, can certainly lead to arrhythmias, so just be aware of that. Also hypertension as well, so it can make some of your antihypertensives work a little less well. And then the final drug in this group is the newest one, this is Chantix or varenicline. This one's really kind of interesting because it's a partial nicotine receptor agonist. So it means that it binds to the receptor and it activates it, but not to the same degree that nicotine does. So it's only a partial agonist. So the idea here is that even if you were to smoke while on this drug is kind of binding up those receptors, and it binds tighter than nicotine does, and so it prevents the nicotine from actually activating it. So you don't really see the same kind of interaction you would see if you had a nicotine supplement on board with smoking, right? So the idea here is that you can actually start this drug, they can continue smoking for let's say like a week or two, and then they can taper that off, and then they can just be on this drug, right? And by activating those nicotine receptors to a small degree, you prevent some of those physical withdrawal manifestations. So then the other thing here is that you see a lot of CNS effects from this drug. So you can see certainly sleep disturbances. I hear people talk about very, very vivid dreams they have while being on Chantix. And there's also a black box warning for neuropsychiatric events. So worsening depression, suicidal ideations are all possible. So if your patient already has a history of that, this may not be the drug for them, right? Or maybe something at least to warn them about that if they experience worsening depression, they need to call you up so they can maybe be on something else.
I heard with Chantix, it takes a couple of times
Not necessarily, but you see, like here, like they say to start 1 week before the quit date, right? So that way they're at least have the drug on board. So that way when they stop the smoking, like they still have something on board that's kind of already activating those receptors. So they're kind of already gotten used to the drug to some degree. So that's kind of where they put that there. Yeah. Okay. As far as immunizations for COPD goes, it's really, really important that they get their annual influenza. Very frequently you see patients who will have COPD, especially in the wintertime months. They come in with the flu and they get very, very nasty secondary bacterial infections, or you can see really bad pneumonias pop up. So they're definitely at risk. So have them get their flu shots. And then also they should make sure they get a pneumococcal vaccine, right? Make sure they're up to date on that, because again, they can be more at risk for having pneumococcal infections. So those are the two big ones that you make sure they have. Okay, so any questions on that stuff?
Have that coffee cup.
Hmm?
Have that coffee cup.
Do you? Nice. All right, moving on. We'll talk about some cardiovascular pharmacology. So in case anyone was tired of antibiotics, I have a few more for you. Okay. So the first thing we'll talk about is going to be infective endocarditis. It's not something you're going to see super frequently, but when you do see it, it's something you definitely want to treat appropriately the first time. Basically, this is going to be a bacterial infection on the lining of the heart or on the valve itself. You end up getting these little vegetations, little colonies of bacteria that like to settle on the valve. Big risk factors for this include older patients, male patients, especially if they have injection drug use. This could be a big issue. That poor dentition, it can lead to hematogenous spread of some of these bugs. Structural or valvular heart disease, especially if they have a mechanical valve put in place, they are going to be more at risk for having endocarditis. Okay, so it's a big issue. If you can't treat it with antibiotics, guess what you have to have done?
Valve replacement.
Valve replacement, right? So if you can avoid open heart surgery, it's probably a good thing, right? So, yes.
Is this what can happen from rheumatic fever?
Hmm?
Is this what can happen from rheumatic fever?
You get a inflammation of the heart, but not really like a bacterial endocarditis. Yeah, you can certainly see endocarditis. You can see cardiomyopathies from that. We'll talk about that in a little bit, but it's not necessarily a bacterial one that you'll see. Okay, so again, as you can see, a formation of a thrombus on the abnormal endothelial surface. That's one pathway for that vegetation to start up. And then usually a bacteria coming from the bloodstream can get deposited on there and just start to colonize and start this proliferation. So it's very difficult to treat these in a lot of cases. You need a lot of antibiotics for a long period of time, because on these vegetations, it's very difficult to penetrate through and actually get a full kill for all those bacteria, right? So it's not the same as if you were treating like, a bloodstream infection where you can just administer drugs in the bloodstream and it kills them all. This is a very kind of concentrated core of bacteria that's tough to penetrate. So we'll see drugs that have to be used for, say, up to 6 weeks, 8 weeks, 12 weeks in some cases in order to really help treat this. The most causative organisms we'll see here are mainly going to be your gram-positive, so we'll see a lot of drugs that are going to focus on that. So you have Staph aureus being responsible for about 30 of these cases. Enterococci can be here, Streptococcus bovis, other things like that. And then you also worry about some of these haystack organisms, so this is a group that fall into that category. Obviously if you have immunocompromised patients, that's where you're more worried about things like gram-negatives, you worry about fungi, things like that. But for most of your patients, gram-positives are the main bugs you're going to be focusing on. So you'll see that the therapy really needs to be geared towards the cultures, and because you're going to be treating for the course of several weeks, you're typically going to start them on empiric coverage, and then when you get those cultures back, you're going to be able to decide what type of therapy is going to be more appropriate for your patient. So we'll talk about what you use for empiric coverage and then what you can scale down to based on the causative organism. Most of the time you're going to be focusing on MRSA, MSSA, strep, and enterococci for empiric coverage. So this is a big group because they're the most common ones you want to cover for. We like to use bactericidal antibiotics if preferred, because again, that's going to help to lead to better kill instead of just inhibiting the growth of those. It's going to help to get rid of that vegetation as best we can. And so a good initial choice is going to be vancomycin, right? Especially when we don't know what the patient has. Specifically, growing vancomycin is a very good coverage for this, including MRSA, right? And like I said, treatment may be needed up to 6 weeks. You may even see longer than that depending on certain patient circumstances. So if you say you start vancomycin for your patient, and then you have, say, viridin strep or Streptococcus bovis come back, these typically are going to be very penicillin susceptible, and that'll show up on your cultures. It'll say pen susceptible. Typically, you can get away with using something like penicillin G for this. Sometimes you'll actually either see it given, say, 4 to 6 times a day, because remember, it's one of those time-dependent killers. Or in some cases, you actually see 24-hour infusions be done in order to make sure you're staying right above that MIC, make sure you're getting as much bacterial kill as you can on that vegetation. Other alternatives include things like ceftriaxone. You see, 2 grams every 24 hours. IV or IM could be potentially used. Vancomycin can continue to be used if they couldn't receive a cephalosporin or penicillin for whatever reason. And in some cases, you might actually see gentamicin being used for gram-positive synergy. So this is one of the few cases you'll ever see gentamicin or an aminoglycoside being utilized for kills of gram-positive bugs. Okay. The idea here is that by giving a cell wall active drug like vancomycin or ceftriaxone, you kind of loosen up the bacteria and allow gentamicin to kind of get into the cell to have its mechanism of action. You guys remember what gentamicin did?
Covered for chlamydia?
No.
Oh, you mean the mechanism?
Yeah.
Slides into the
Yeah, it inhibits protein synthesis at the ribosome, right? But it's a bactericidal agent. Normally, you only see it used for gram-negatives, but this is one of the few cases where you can use it for gram-positive synergy. So if you hear that, that's where what we're doing this for. The nice thing about this is you can actually use it to shorten the course of therapy, so say every 2 to 4 weeks instead of 6 weeks, which could be very cost-effective for your patient, especially if they're in the ICU or something. Keep in mind, you still have to do your therapeutic drug monitoring, make sure they're not accumulating too much drug because you worry about renal and otic problems, right? So say they had strep pneumo come back again. A lot of these are going to be penicillin sensitive, but just follow your culture results. If it comes back sensitive for say ceftriaxone and not penicillin, then again go with that. Looking at your enterococci, these again, generally you're going to want to go for that gram-positive synergy, so you can use gentamicin plus, penicillin, ampicillin, vancomycin, whatever the cultures are coming back at. And then for Staphylococcus, specifically if it's MSSA, you can get away with using a anti-staphylococcal penicillin like nafcillin, oxacillin, potentially cefazolin if they couldn't receive a penicillin. And then you can do plus or minus gentamicin. Again, if you add gentamicin on, you can shorten therapy. And then if it's still MRSA, vancomycin is going to be your go-to, right? And then if you grew one of these haystack organisms, again, you can see about 5 to 10% of cases might be these gram-negative bugs. A lot of them end up being, they used to be ampicillin susceptible, but now a lot of them are producing beta-lactamase. So you have to add on a little bit broader coverage. So something like ceftriaxone, ampicillin sulbactam could cover this, or even in some cases, ciprofloxacin might potentially be used. As far as injection drug users go, obviously they are going to be much greater risk for all kinds of different bugs because they are introducing these kind of skin flora and all kinds of, because they always use super clean needles, right? Obviously, lick it off first and then use it. Yeah, so they're a big risk, right? They're a high risk population. They can inject things like particulate matter, especially if they're, if they're using like cotton or things like that to filter the drug, or if they're crushing up tablets and things like that. All kinds of junk that can be injected into the veins that can, produce that vegetation. You can end up seeing, tricuspid damage from this. You have skin flora and use of saliva. So all kinds of bugs could be potential players here. You do see Staph aureus being probably responsible for a little bit more than half the cases, but then you also have to worry about gram-negatives and fungi as well. So again, follow your cultures. That'll kind of guide you into what kind of drug you want to use. So again, vancomycin is probably a good go-to as a first line. So with prosthetic heart valves, this is going to be a little bit more difficult to treat because again, you have this nice big foreign body of a valve that's in place. A lot of times you're going to see failure of antibiotics because it just can't penetrate that vegetation enough. Oftentimes you're going to require surgery. But what you can do in the meantime, so especially if you have a patient who came in, they have a prosthetic heart valve and they come in with symptoms of endocarditis, you actually want to go ahead and use a 3-drug regimen. Okay, so this includes usually vancomycin, or if you could scale back therapy depending on what your culture results come back as. And then you're going to use gentamicin for that synergy. And then the 3rd drug you're going to use is going to be rifampin. And so we probably haven't talked about that one before. We might have. Oh yeah, we talked about it during TB, yeah. So we'll kind of mention it here again, but that'll be the 3rd drug that we're going to add on to this regimen. Again, frequently if it's MRSA coming back, probably going to require surgery. So rifampin, we mentioned, what is a kind of unique side effect with this one?
Orange fluids.
Yeah, orange, red fluids, tears, urine, everything can be kind of stained a little bit. So the big thing here is that it has a unique ability to help kill staphylococci that adhere to foreign material. So that's one of the big reasons why we use it for this circumstance. We know that resistance is possible, and so this is why we add the drug as the last agent. Because if we used it by itself or we used it first, you can see resistance develop more quickly. So here you typically want to start with the vancomycin, gentamicin, and then this is the 3rd agent you would add on. Right? So you give this one last.
This isn't cardiac, but like if you had a knee replacement or something, this would be the same thing because it's a foreign material.
Potentially. Depends. Yeah, usually you can get away with like vancomycin. You don't really see the same kind of like vegetations as you would see like in the heart, you know. Yeah. So again, this is going to work by inhibiting RNA polymerase, blocking the RNA transcription. You know, obviously we use it in tuberculosis that we mentioned before, and just the big discoloration there. What kind of the drug interactions did we talk about with this one? You guys remember? Does it inhibit or induce CYP? This actually induces CYP. This is one of the unique ones that actually induce CYP enzymes like 3A4, where you can actually see decreased levels of other drugs. So this is a big one to remember there. As far as prophylaxis goes, frequently you'll prophylax patients for endocarditis. This is probably more based on just a theoretical advantage than actual clinical data to show that it works out well. But the idea is by giving prophylactic antibiotics prior to a potential bacteremia, you can prevent that vegetation from starting off in the first place, right? So if you have a high-risk patient, say they have a prosthetic heart valve in place, or they have a history of infective endocarditis, or some degree of kind of structural abnormality, it's like a congenital heart disease, those would be a patient you want to put antibiotics on beforehand. So what's kind of a high-risk procedure you think you might want to put them on antibiotics before? Sure, if you had heart surgery or any kind of surgery. Yeah, dental's the one of the big ones. So if they have like any kind of dental procedures, like the root canal, because that's a big area for spread of bacteria from the mouth into the bloodstream, that's a place you definitely want to give them some prophylactic antibiotics for. So again, not just routine cleaning dental work, but certainly this is a very high risk, especially if you have any kind of perforation of the oral mucosa. But again, if they're having, say, a bronchoscopy done, if they're having tonsillectomy, really any kind of skin or musculoskeletal tissue being, interfered with, surgery, things like that, those are the ones you want to protect them for. You want to give these 30 to 60 minutes beforehand to make sure you have good bloodstream concentrations prior to the procedure. So if you frequently have patients who come in, say, from the pharmacy side, they come in with the prescription for a one-time dose of amoxicillin 30 minutes prior to procedure, right? So that's a frequent prescription that you might see for that prophylaxis. So amoxicillin is a go-to drug for that, and then as an alternative, you can use something like cephalexin, clindamycin, or azithromycin, right? Okay. Any questions on endocarditis? All right, just know who to use as the triple drug regimen on. Remember how we are going to put rifampin on as the last drug there to help prevent resistance.
I'm sorry, you said that rifampin induces what?
3A4, yeah. So CYP3A4.
Oh.
Yep. CYP3A4 is responsible for 50% of drug metabolism, so good one to remember. So next we'll talk about rheumatic fever. So as we mentioned before, this is a non-suppurative complication of pharyngeal infection, so typically group A strep. It's going to be the big cause here. So you see this end up 2 to 3 weeks following pharyngitis. So you can see lots of different effects, arthritis, carditis, subacute nodules, all these different things. And you really see this being a big cause of cardiovascular death in the first 5 decades of life outside of developed countries. So again, because we have good rapid ways to detect strep, nowadays, we can treat patients pretty early on instead of waiting for them to develop this after the fact. So we'll kind of talk about what happens if they don't receive this up front. Big things though, is one going to be the antibiotic therapy, heart failure management if they develop that, which we'll talk about later on, and then also anti-inflammatory therapy. So again, we talked about kind of the go-to drugs for strep pharyngitis. Amoxicillin is really going to be the big one there. Penicillin might be as an alternative, and that's going to help to eliminate that group A strep carriage, right? For the carditis that develops, if it does develop, if you didn't treat it early enough, you can we'll treat CHF as appropriate, which we'll talk about in a couple of lectures. But they may also need things like valve surgery. And the main drug to go to for their inflammation is going to be aspirin. So you can actually see between 4 and 8 grams a day being given to help deal with that anti-inflammatory effect. If that's not continuing to work, if that's not really dealing with the inflammation, then you may need to add on some glucocorticoids. So things like prednisone could be used then. So that's kind of the main way you're going to manage that disease. Okay, so moving on, and actually this will be the brunt of the first part of the cardiology lecture, is going to be our lipid-lowering agents. So lots of sources of dietary fats. Main one's going to be mainly from our diet, and then also from our body actually producing the cholesterol itself, right? Have you guys covered this in other classes already? Okay, so we will talk about kind of the basics of it. I'm not going to get super into detail on the pathophysiology because obviously we want to focus on the drugs, but we'll at least get you enough to know how the drugs are going to work. So looking at a typical American diet, which who knows how typical this is anymore, obviously obesity being a big problem, but triglycerides, see about 100 grams in a day, and then 250 milligrams of cholesterol being ingested. And so when you ingest these from the GI tract, you're going to see that the triglycerides and the cholesterol gets incorporated into these molecules called chylomicrons. And so you're going to see as we get these chylomicrons being metabolized, you're going to see the ratio of triglycerides and cholesterol is going to change as we go along. Okay, so just keep that in mind. So again, dietary cholesterol is going to be ingested through the GI tract. You're going to see that a lot of that's going to be emulsified by the bile acids. And the bile salts are going to be sent out to the biliary tract. That also contains a lot of cholesterol as well. So you're going to see this reabsorption of that cholesterol from the biliary tract. Okay, that's going to be an important source for, or at least an important site for one of our drugs to be working to actually prevent that reabsorption of those bile acids. But anyway, those bile salts come in and they help to emulsify the fats and whatnot, and they will allow for the cholesterol to be absorbed into the GI tract. So it goes into the epithelium, and then eventually, what's the first organ it's going to hit after that? Yeah, the liver is going to be the first place it's going to go to, right? Good. So anyway, so it gets incorporated in the chylomicron, and the next thing it's going to do is going to end up going to the liver. So from the chylomicron, you're going to see that the triglycerides in the core of the chylomicron end up getting hydrolyzed by this lipoprotein lipase. And so you're going to see that you'll have, as time goes on, that the triglyceride content is going to go down as more of this gets converted over into cholesterol. So you can kind of see there, if you look on the chylomicron, how there's a big proportion of green to it. Again, those are your triglycerides, and as the metabolism continues, you'll see that the yellow portion gets bigger and bigger, and so that means you have a higher proportion of cholesterol esters. And that's where we're going to see that our triglycerides that we measure in the bloodstream are going to come from, and we'll also see our LDL and HDL will end up coming from these chylomicrons, right? So once the cholesterols, once they're in the liver, they can be used to help synthesize things like cell membranes, hormone synthesis. They can also be disposed of as the bile salts as well. So they can help to start that recycling process to help absorb more fats from the diet, right? So when that happens, when you have things that are being kicked out from the biliary tract being reabsorbed through the GI tract again, that's called enterohepatic recirculation. Certain drugs will end up going through this. Things like birth control can do it. Certain anti-epileptics can do this. And this helps to prolong the half-life of certain drugs, right? So it's an important thing to consider. We'll see drug interactions that can actually come about from interrupting that enterohepatic recirculation. So you can also see carbohydrates and other fatty acids being converted to triglycerides. And then what you see being excreted from the liver are these VLDL, or these very low density lipoproteins. Notice here they have a higher proportion of cholesterol esters, but they're still primarily made of these triglycerides. And again, when you're looking at the triglyceride content in the blood, usually you're measuring these VLDLs and these IDLs, or the intermediate density lipoproteins. So just as the metabolism continues to go on, you're seeing a higher proportion of those triglycerides being converted over into these cholesterol esters, okay? That's that lipoprotein lipase that continues to do that. Eventually, you're going to see that by further metabolism, you're going to have the LDLs actually produced. And we know the LDLs are what kind of cholesterol? The bad cholesterol, right? Because they're going to lead to things like arteriosclerosis and plaque formation, all kinds of bad things. So LDL itself is actually removed by this LDL receptor. Kind of makes sense, right? LDL receptors are found primarily in the liver, and this is how we're going to end up metabolizing and getting rid of those LDLs, right? So the more functional and the more LDL receptors that we can put out on the liver, the more LDL we can clear from the bloodstream, and that's going to be a good thing, right? Because when you get rid of LDL as much as possible, and that's where we're going to see a lot of our drugs working at, is going to have a side effect of increasing LDL receptor concentration. So here you can kind of see the ratios of triglycerides to cholesterol with the chylomicrons, 10-to-1 ratio. Whereas when you get down to your LDLs and your HDLs, which are typically your protective cholesterols, you really have mostly just cholesterol esters being the main components there. Really very few triglycerides, right? So that's why when you measure triglycerides in the blood, you're looking at your VLDLs and typically your IDLs as well. That's where that number is going to be coming from. Yes?
I'm sorry, is the VLDL is good cholesterol?
No, it's just a kind of an intermediary. It's just where you see a lot of your triglycerides in the bloodstream are coming from. They're actually are incorporated into this, but when we measure them in the bloodstream, that's what we're measuring. That make sense? Yeah, so, you always have triglycerides floating around the bloodstream to varying degrees, so especially like after meals, like it's going to be increased, but when you are measuring triglycerides in the bloodstream, obviously you don't have a ton of just free-floating triglycerides. Many of them are contained in these VLDLs. Yeah, so as time goes on, as they get more and more metabolized, they'll end up turning into LDLs eventually, as those triglycerides get, because some of it's going to get taken up into tissue where it can be used for, to produce hormones or produce, cell membranes, things like that. So all the while as they're circulating, they can be taken up by the tissue, or they can be gotten rid of by the liver, because the liver is going to be the main place we're going to be metabolizing all these cholesterols. So big thing here, if you notice on the LDL, when looking at the mechanism of catabolism, you're going to see that the ApoB100 is going to be the major receptor. Basically, it's a protein that will be on the surface of that LDL that's going to interact with that LDL receptor. So I'll show you a picture of that in just a minute, but just know that that ApoB100 is going to be important for catabolism of LDL. Okay, so see that apolipoprotein, the little orange guy there? And then you see the yellow one, that's going to be the B100 that we mentioned there. Those are what's going to interact with the receptors. And typically when you're looking at these apolipoproteins, like your VLDLs and your LDLs and things like that, you're going to see this this essential core where basically you have this lipid membrane, and inside you're going to see your cholesterols and your triglycerides. Okay, so that's generally kind of what they look like. So looking at the low-density lipoprotein, because this is obviously the main one we're going to be focusing on for our medications, you can see that these are going to have a half-life around 1.5 to 2 days, and that ApoB100 is what's actually interacting with that LDL receptor. And so you can actually find patients who have changes where they may not be expressing as much of that receptor, or they may not be expressing that ApoB100, and actually lead to very high cholesterol levels because they just can't process it through the liver like a normal patient could. So anything we can do to help increase, because again, if you're thinking about the liver, if you think about upregulation and downregulation, if you have a ton of cholesterol within the bloodstream and it's constantly being taken up, the liver can only take up so much, and eventually, what are those LDL receptors going to do? They have just way too much cholesterol around. Yeah, so eventually they're going to deposit into the arteries and things, but the LDL receptors are going to downregulate, right? So if I can do anything to decrease the bloodstream concentration of LDLs, that's going to help to lead to more LDL receptors being put on the liver, because it says, hey, I don't have enough cholesterol in me. Let me go ahead and try to suck up more than I can by putting out more receptors. I'll show you a picture of that in a second, but just keep that process in mind. So just like you see here down the bottom, lower LDL receptor activity means more accumulation, which means more atherosclerosis. So that's the main thing we're trying to prevent there. So again, looking at your LDL, you see the ApoB100, that little green guy there, interacting with the LDL receptor. They're going to get taken up into the liver, where it can do things like metabolize it, get rid of amino acids, use things like get the cholesterol out, so it can start making bile salts, all kinds of different things that the liver does with the cholesterol. And then eventually it's going to recycle that receptor and put it back out onto the surface of the hepatocyte, right, where it can then take up another LDL. So again, if you have way too much cholesterol within the liver, which also probably means you have too much in the bloodstream, you're not going to want to be putting out as much of those receptors, because it says, hey, I got enough cholesterol. But if I decrease production of cholesterol, if I decrease what's in the bloodstream, then I'm going to be able to put out more receptors and be able to catabolize more of the LDL. So the drugs we look at, we'll see how that's going to have, how that effect will really occur. So just an example, if you have patients who have mutations in their LDL receptor pathway, so you can have patients who have this either heterozygous or homozygous familial hypercholesterolemia. Just as an example, they have patients who may be lacking the genes for these LDL receptors, or may have a mutation. You can have patients with cholesterol as high as 1,000 milligrams per deciliter. And what's kind of a normal cholesterol? Anyone know? Yeah, like around 100 or so, like we consider to be, usually that's one of your goals, like when you're treating hyperlipidemia. But obviously 1,000 is going to be way too high, right? So that's going to be a major problem. You see a lot of increases in atherosclerosis in those patients, so that can be a big issue for them. But most of your patients are not going to have that issue. They probably just have poor diet and poor genetics to make them have a little bit higher LDL. So anywho, this is the typical breakdown of your components here. You can see around 70% LDL, HDL is anywhere between 20 and 30%, which we know that to be our protective good kind of cholesterol. And then those VLDLs, that's where we see the majority of our triglycerides being measured from, right? So the drugs that we can use to treat dyslipidemia, here's kind of the different sites where they're going to be working. I'm going to go into more details on each of these, so just so you can kind of refer back to this picture as we go forward. So here are the different classes here. You can see the HMG-CoA reductase inhibitors, otherwise known as our statins. These are going to be our main go-to drugs. So because especially of guideline changes, these are the major drugs that you'll see used for treating hyperlipidemia and being used for their cardiovascular protection. We'll also see drugs that help to inhibit the absorption of cholesterol, so ezetimibe will be the one in that category. You also have drugs like fibrates, bile acid sequestrants, which will also help to modify the catabolism and handling of LDL. And then you also have the nicotinic acid drugs. So we'll go into more of these details as we move forward. So I'm going to keep talking for just a few more minutes if you guys don't mind, just because we're held up with this quiz. So anyway, so the first group we're going to talk about is going to be our statins. So these are HMG-CoA reductase inhibitors. So what do you think the mechanism for these drugs are? HMG-CoA reductase, right? Perfect. You guys know already. I don't have to teach you stuff. So these are the drugs that fall into this group. So certainly this is probably going from mostly lowest potency to highest potency. Simvastatin probably should be a little bit higher up on the list. Just realize though that these agents do have different potencies, so you'll see the doses will range somewhat significantly between the different drugs. So say for instance, 5 milligrams of rosuvastatin could be equal in efficacy to say 20 milligrams of simvastatin or 40 milligrams of say lovastatin. So just know that there's differences there. You'll see differences in the dosing based on the potency of the drugs. And actually when we look at our newer guidelines that will focus on intensity of statin therapy, you'll see certain ones really just you can't drive the dose up high enough to really get as high intensity as you want. So you'll see certain drugs will be considered ones that are good for high intensity use, so things like rosuvastatin, versus ones that are probably not going to be used quite so frequently. So we'll talk about that as we get to it later on. So looking at the process of generating cholesterol within the liver, you can see it's a very long kind of multi-step process here. The main thing to focus on though is that HMG-CoA is an enzyme that's or this reductase is responsible for helping with that production of cholesterol. So the statins can come in, block that enzyme, and then you're going to lead to less actual LDL being made in the long term. Okay. So what that actually means for you guys is that by decreasing cholesterol synthesis, that means we're going to have less cholesterol within the hepatocyte. And because it has less cholesterol in the hepatocyte, they're going to say, hey, we need more cholesterol in here. Let's put some more receptors out on the hepatocyte. So it increases the number of receptors on the cell surface, which means you're going to be taking up more cholesterol from the bloodstream, things like your VLDLs and your LDLs, and using those for whatever the liver needs it for, right? Whatever happens to be. So in general, you're going to end up seeing decreased serum LDL. You're also going to end up seeing less VLDL and IDL, which means your triglycerides are going to go down as well. Okay, does that make sense? So all of it has to go back to increasing the number of LDL receptors around the hepatocyte so you can start to take up more LDL from the bloodstream. Any question?
I was curious if you're taking it out of the hepatocyte, whereas it's going into the bloodstream?
No, because usually whatever those remnants are, they might have some other pathways or might end up getting metabolized and then excreted elsewhere. But the majority of it just does not become cholesterol. So that's kind of the end product you need to worry about, is that you're producing less cholesterol within the hepatocyte, so it needs to take it exogenously from the bloodstream. Okay. So the other big benefit of statins, and they found this with large studies that actually looked and they see that there's additional benefits. So outside of just its mechanism of action, has all these other really positive benefits for your patients. And these are called pleiotropic effects. These are effects that are positive, but they don't really directly related to the mechanism. So we see things like improved endothelial function, you have stabilization of some of these plaques, and so you can see why based on all these different things you have good effects on mortality, especially in regards to cardiovascular death. So with patients who are on statins, you see less cardiovascular death in them. They've looked at huge numbers of studies and huge number of patients to see that. So this is why they are very frequently recommended for patients with any kind of cardiovascular disease or big risk of having cardiovascular disease. So patients with diabetes, patients that have high LDLs, those that are high risk for cardiovascular death, like patients probably need to be on a statin unless they have some kind of contraindication to receiving it. Okay, so we'll see if the guidelines kind of bear that out. So just memorize the slide. Don't do that. Main things I want to point out here is just kind of a broad category or broad comparison of the different drugs. One of the big things I want to note is the metabolism, the major enzymes here. Notice that CYP3A4 is a very prominent one on these. This is a big source for drug interactions, meaning that they do not inhibit CYP enzymes, but they are metabolized by it. So if I have another drug that comes along and inhibits that CYP enzyme, I'm going to see increased levels of statins, and then that leads to what? more toxicity, right? So increased levels means more toxicity, and that can be potentially fatal for some of these patients, depending on what it is. Note, though, that some of them don't have any CYP interactions, right? So that would be an important thing to know for your patient, especially if you're prescribing a new drug, like say they come in with a pneumonia and you want to give them macrolides that inhibit CYP3A4. It's important to know if they're going to have an interaction there. So things like rosuvastatin doesn't have any CYP, major CYP metabolism. You know, things like pitavastatin don't either. So those are good ones to prescribe for your patients because they lack those drug interactions. And just looking at using combination therapy, you frequently will see multiple agents used for hyperlipidemia together because you get synergism there. So you end up seeing better effects by combining these drugs than you would see with either one used by itself. So if you look here, you can see statin lowering the LDL by itself, and then you can also see it put on with, like, say, a bile acid sequestrant or a resin. You can end up seeing kind of synergistic effects there. So very frequently you'll end up seeing multiple drugs being used at the same time, especially if you don't get adequate therapy with just the statin by itself, right? So it's important to know which ones you can mix together to avoid some of these drug interactions. And so the other big thing you can see is effects on triglycerides. So the higher your triglyceride levels in the bloodstream, the better effects statins are going to have on this. So if you look here, if I was giving simvastatin 10 milligrams, and, their baseline triglycerides are less than 150, that's a normal level. You might see very minimal effects on that. Versus if they're, say, greater than 250, now I'm going to say about a third reduction in your triglyceride levels. Right? So the higher triglycerides are, the better effects statins are going to have on that. Something to note there. Okay. So I think I'll probably call it there. We'll resume next week, and lots more cardiology to go to. So, yes.
Is it the reason why they work better is because there's more for it to do, like there's actual work for it to do?
Exactly. Yeah. Exactly. So if you have a normal level of triglycerides, it's just that's what your body's used to. That's the normal homeostatic amount. You start to increase that more, it has more to work with. So.